Welcome to the For Health's Sake podcast, brought to you by Edito Health, elevating digital transformation with a human touch. This episode is sponsored by Radical Health Festival and our lead clinical partner, the European Society of Cardiology. It's critical to be radical.
Hello, I'm Charles Alessi, the Chief Clinical Officer for Edito Health. And this is part of the For Health's Sake conversations. And I'm joined today by Professor Gerhard Hindricks, Director of Cardiology at Charité in Berlin, as well as Chief Integration Officer of the Heart Center there. Gerhard is also the head of the Digital Health Committee at the European Society of Cardiology. And today we have an opportunity to really delve a little bit deeper into digital health and the effects it's having upon non-communicable diseases. As we know, now in the treatment and management of non-communicable disease, we're thinking in terms of a life course intervention. In other words, getting people engaged before they develop symptoms as well to hopefully stop them getting the symptoms. But also we have a real opportunity with digital health, both around personalizing care, extending reach of clinicians, engaging patients or citizens substantially more. And then, of course, we have the use of AI, both in terms of outcomes, in terms of acute settings, but also in terms of the journey around life course. But let's start having this conversation. And really, we should start considering that GERD is within an acute setting at the moment, talking about how digital health has improved acute settings. And what's your sense of all this, GERD?
First of all, Charles, it's a privilege and pleasure to join you today and to contribute to the discussions around the urgent needs for digitalization in healthcare to improve the quality of care for citizens and for patients. I believe that digitalization is one of the biggest opportunities that has ever been given to medicine in the whole history, in total history, in acute settings, in chronic settings, in the prevention and prediction of disease. And we are just at the beginning to understand what new opportunities we may have to prevent the occurrence of disease, to slow down progression of disease, or even to be curative in many different states of disease. I would like to address one more point that I personally consider particularly important in the field of digitalization in medicine, and that is the element of access to medical care in a global perspective, but also in a European perspective. Digitalization will help us to overcome the unacceptable inequalities in access to care, because it will allow us to be closer to the citizen and closer to the patient. It will open up new pathways, how people that need medical support can get in contact with the healthcare system. So a lot of the roadblocks that have been set in the traditional healthcare system can be completely taken away by digitalization. So the bottom line is, Charles, digitalization is a huge opportunity in medicine to improve the quality of care at various stages.
Yeah, and when we say access, Gerd, it's really useful, I think, for us to consider access in different dimensions, because we think in terms of access and inequalities, often meaning richer countries as against somewhat less rich countries. But within countries, of course, we have this rural city divide. Not everybody's at the door of Charité.
It's reflects the realities in Germany. I mean, we have rural areas outside the big cities where there are hardly any physicians with subspecialization available. So in some parts of Saxony, you have to wait 6 months. We talk about Germany. 6 months to get an appointment with a cardiologist or even with an oncologist. And this is simply unacceptable. And I believe that elements like telemedicine, telecare, digital biomonitoring offer so much to overcome this unacceptable situation. So the point is very, very clear and gets my full support, Charles. It's not only a topic for the so-called evolving geographies in the global perspective. It's something which also addresses the needs in Central Europe and in Germany. One more point on that perspective. Medicine will continue to be limited by the limitations of financial resources. And we have to be more efficient in delivering better quality of care. And there are limitations in the traditional healthcare system. So also from healthcare economical responsibilities, we have to speed up to implement digital elements into our healthcare pathways to make medicine better payable and more affordable to more people in Germany, Europe, and around the globe.
Yep. I can't say anything more than that. That is perfect in terms of where we need to go to, I think. I don't think anybody would disagree. But let's look at acute settings for a moment. You work in an acute setting in a major, one of the global major hospitals. What have you seen as terms of the advantages of digitization within your acute setting? I mean, you know, we talked earlier about the fact that even some things which are synonymous with the physician may be things of yesterday. We talked about the stethoscope, for example, perhaps not being quite what it used to be. We could say the same for the EKG. What's your take on all of this?
In the acute settings, in emergency rooms, and other environments in the hospitals, also at high-end university centers, the improvement of the speed and quality of diagnostics to come faster to diagnosis and treatment can be intensely promoted by digitalization. You've mentioned some of the right technologies and items. There will be a revival of the stethoscope, the digital stethoscope in medicine. I'm honest, I haven't used the traditional stethoscope for the last 10, maybe 15 years, because the risks of transmission of diseases by stethoscope was higher than the potential benefit, because there are so many limitations. It's using the traditional stethoscope. It's the experience of the individual using it, and it's also limited by all limitations of hearing things, frequencies. So with digital stethoscope, there will be a completely new opportunity to use the data that can be taken with digital technologies from the body. It goes far beyond just the normal heart sound or the sounds of breathing. It will extend into the analysis of biosignals that are unhearable to the human ear, that will be connected to automatic data analytics and to immediate feedback to the physician. This gives us the bridge to the question, who will have what responsibility in the digital healthcare system of tomorrow? If there is no specific experience required to take the data from the patient, if it's just the act of moving the stethoscope the digital stethoscope in a strategic way of the body of the patient, it does not necessarily have to be a doctor to do that. It does even not necessarily have to be a trained nurse to do that. We can use other people and ask other people to do that and come up with the same quality. Having said that, it shows that the implementation of digitalization in acute medicine offers us a completely new way and speed to get to diagnostics. Let me extend a little bit on the ECG. The ECG used to be something like PQRS-T, rhythm and rate, bang, that's it.
That's what I learned.
Yeah, that's what I learned, and that's what I teach for decades. But with the availability of digital ECGs and algorithms that are able to analyze these ECGs, the view of the ECG, the range of things that you can see from the ECG is multiplied by at least the factor of 10. You see 10 times more in the digital ECG than the eye of a trained cardiologist can take from the ECG. It goes far beyond rate and rhythm. It goes into the field of recognizing arrhythmias that took place in the past, detection of atrial fibrillation. It goes far beyond even cardiovascular information, because there's also information about age and gender of the patient. There is information of cardiovascular function, pump function. There is information about pulmonary hypertension that you can take from a digital analysis of the surface ECG. Let me extend on one more point, Charles, that I consider particularly important, and that is cardiovascular self-assessment. Here at the Charité, we are building up one of the first cardiovascular self-assessment centers driven by digital technology in order to speed up the moment where the patient enters the hospital until you have a key set of cardiovascular basic data. That's the ECG, that's blood pressure, that's oxygen saturation. That will include voice recognition and voice analytics, and it will also include facial viewing. All this can be done without the presence of a physician. It can be guided by a nurse, but the main steps of bringing this information into the hospital information system is done by the patient. And we're going to do that. People that don't like me always say, well, Gerhard, you want to transfer healthcare into supermarkets where people scan the things that they buy and then pay. And I say, yes, that's exactly what I'm going to do, because it improves the quality of care. And it's better to motivate the people and the patient to contribute to their health and to their diagnostics, rather than putting them into the hospital and let them wait for 4, 6, 7 hours until somebody takes care of them. So all this will open up a completely new window in cardiovascular care and in medicine in general. We simply have to be courage enough to leave traditional paths and try something new.
Well, I mean, what you described is a totemic change in terms of the improvement in outcomes, which one would expect to result from this level of care within an institution. But let's take that a little bit further now, because of course, people don't live in institutions, they live outside institutions. And clearly, one needs to actually manage care outside the institution as well as within the institution. Now, clearly, there are potential opportunities that digital health allows one to keep engaged when one is outside a hospital setting, of course. And clearly, that's within the thinking that you are going through in terms of setting up this center. But there are other players in this. And if we're really thinking in terms of the personalization of care along a life course, we are still thinking in terms of extending the reach of clinicians, which is what you describe. You don't need a doctor to do everything. And you're talking about much more engagement of an individual, a citizen, a patient within the care. But we have to be honest about this. In Europe, we are in a difficult place in some respects, because even though it is wonderful to think of designing a system from nowhere, in actual fact, we have a few things in the way before we can develop this care. We still don't have that interoperability that we think is so easy to achieve.
Yeah.
Technically it is, but actually in reality it has not been. We still do not have the same focus on care between the different, I'm going to call them tribes of clinicians, some within hospitals, some outside of hospitals, who are not necessarily quite as enjoined. This is not a German issue, by the way. This is an issue all over Europe. So we know that there is a disconnect between primary care and hospital medicine in many respects. And in cardiovascular medicine, you see it so much more sometimes, mainly because you're so much more advanced in your thinking around holistic care. How are we going to change this? Because we need to change this. And really, what we're here to do today is to have a conversation about it, but also to start thinking in terms of, let's make the first steps to actually change what we have now, which is real dysfunction. What are your thoughts around this?
Yeah. Everything very well said and very well understood, Charles. And you're addressing the most important elements that would enable us to implement the technologies that are existing today for the benefits of the patient. So we need standards that allow interoperability of different technology streams. So we need standards for data security, data protection that are transparent, that are reachable, and these standards should not be driven by I would say undirected fears that something may happen. They should be driven by a clear roadmap where safety and how safety for data protection can be implemented in the system. Then there is a healthcare political aspects that the legal frame is appropriately set, and this is also part of the truth. We must give the digitalization space. That means traditional elements of healthcare have to be questioned and have at the end of the day also to be taken out. So there is something new to implement, but it has to replace something. This is also a matter of healthcare economics. And last not least, we have to ensure appropriate financing. In medicine, things that work on a wide application scale, they must be financed by the public healthcare system. And I would really like to encourage the reimbursement, the people responsible for reimbursement in the geographies take a clear look to the opportunities of digitalization and give it also financial resources to develop. So
as well as DIGA, financial resources to go with DIGA, but financial resources which actually can be liberated in time to stop organizations and innovators actually go bankrupt.
Yeah,
this has happened.
Yeah, absolutely. We have seen that. We have seen that many times, too many times. So the financial background must be set to allow successful implementation into the healthcare system. Once again, the opportunities are huge, and we simply have to be courage enough to go the next step.
So let's end up with an area of medicine which is particularly problematic at the moment, and it's the one I represent or represented in the past, which is really the primary care world, which is in a significant crisis globally. And the new role of primary care is something which is being discussed, being talked about, because it certainly will not look like it looked in the past. There are people who say that perhaps primary care clinicians will not exist. I don't think they'll exist in the same way they will today, but I think there will be something there, perhaps not the same numbers of them, perhaps not the same roles, but there will be something there. in Germany, you too have issues with your primary care. You have the same issues that we have in different parts of Europe. How do you see us finally break this old-fashioned, really very boring divide between hospitals and out of hospitals? Because really, it's a debate we've been having for 40 years, and I'm getting very tired of having this discussion.
Again, Charles, digitalization offers us the hugest opportunity ever to overcome this this problem that we have seen for many, many decades in various healthcare systems. Two perspectives. One is what's going to happen to the primary care physician of the future. I believe that it's would be a very, very smart move for primary care physicians to progressively move into digitalization, to take out the benefits that they can gain. They can substantially increase the width of their diagnostics and therapeutic responsibilities in the field. That is one. The second is the transsectoral hurdles and boundaries that we've seen in the past, from primary care physicians to special non-hospital care to hospital care. This is something that we were unable to overcome with just the normal mode of action in the healthcare system. There were gradual improvements, but there's never been a substantial improvement in the field. With digital elements, the flow of information, the access to relevant information from the various healthcare providing points has substantially increased. The permeability of the elements within the system has substantially increased. And if we manage to get access to digital data in the healthcare system, overcoming the distances between outpatient, primary, special outpatient, and in-hospital care, we would gain substantial benefits. Coming back to your question, what's going to happen to the primary care physician? If the primary care physician follows these two paths within the environment of the outpatient treatment, implement digital elements to improve diagnostics and improve the width of the spectrum of responsibilities, and then connect on digital pathways to your partners, which is the specialized cardiologist, the specialized oncologist, the specialized physician for infectious diseases, and extend then further to the hospital settings, then I believe there is a bright future for the primary care physician as well.
Well, it's important to be radical, and this is a radical, suggestion. And I believe, actually, as one of the people you're talking to, it is a suggestion which I subscribe to. I think it is the only solution, to be frank. So thank you for that conversation. Thank you for the opportunity to start the conversation, which will continue in Helsinki in May. And thank you for your time.
As always, it was a privilege exchanging with you on some items and elements that I've said it before, I say it one more time, gives us the hugest opportunity to improve the quality of care in medicine, and that's progressive digitalization. So join us in Helsinki. We will come up with new radical ideas to make things better over there. Looking really forward to seeing all of you there.
Thank you.
Thanks for the conversation, Charles.